Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD podcast. Troy, it looks like I'm outnumbered today. I'm the sole West Coast representative.
We have 4 doctors here today. This is Dr. Central. We have 2 amazing doctors here that I'd love to introduce. You guys all know Dr. Brian Lenskis, a brilliant guy, myself. My name's Dr. Troy Calkins, if you don't know. And then we have 2 other doctors here, Dr. Matt Calkins, who is a board-certified family medicine doctor, board-certified obesity medicine doctor, metabolic health practitioner, and we're joined by Dr. Laura Buchanan. If you guys don't know her, she also works here in our clinic nationwide. She is also a board-certified family medicine doctor, board-certified obesity medicine doctor, and she is also on the board of the Society of Metabolic Health Practitioners. And we're joined by their beautiful, amazing son, who may make an occasional cough or coo or appearance. So we have 5 guests here today.
Awesome! So glad to be here.
Thank you for having us, guys.
Yeah, thank you. I know Brian read the. So what maybe we can frame the discussion and in September of 2023. As a follow-on to a previous guideline, the American Academy of Pediatrics wrote a guideline on low-carb diets for children and adolescents with obesity or at risk for diabetes. And they recommended that, in general, that adolescents and children do not do low-carb diets. And if they do it, they recommended aggressive radiographic tests, blood tests, but said under close supervision it may be appropriate. And this is the same group who has said that GLP-1 injections in adolescents should not be withheld, and that bariatric surgery is an option that should also not be withheld. So before we get started, and we'll let sort of maybe Matt or Laura, whichever of you 2 wants to, can we all do first names? Hopefully that's okay. But before we get started with that, whoever wants to lead, maybe Brian, how does that make you feel to hear about the AAP's statements?
Well, I think it'll be very clear. I think, it's absolutely astounding to me where you have a drug that hasn't been on the market long and you say, let's give it all these kids without knowing the long-term risks and benefits and things like that. And I think we have enough evidence to say there are definitely long-term bad effects that are going to happen. One of them being when you come off the drug, you gain all your weight plus some, plus you lose muscle mass, plus your increased risk of things like thyroid cancer and things that we may not want to have. So I think it's amazing how we make these guidelines without really diving into the evidence and looking into studies, and it almost seems like people make up their mind before they look at the data and the research. That would be my take on it. Like, to put a kid through bariatric surgery, we from what we know in adults, we're seeing, and Troy, you probably know the numbers better than I do, but at 5 years, we're seeing disasters after that with vitamin deficiencies and all that. So if you're looking at lifelong when kids are developing, you go, man, there's a lot of potential downsides other than of course, the risk of surgery. And so I think, a lifestyle approach, focusing on stress management, sleep, nutrition, proper nutrition, cutting out processed foods. They don't even really mention these things. They just go, try diet. If it doesn't work, then go to these other measures. So that would be my take on it.
Yeah, I'm going to say one thing before I hand it off. These were all separate guidelines, just so the listener knows, and maybe we'll put the notes in there. They had a guideline on bariatric surgery. They had a guideline on sort of obesity management, and they had this guideline separately discussing low carb diets. And I from one hand, I understand the compassion they're trying to have. It's like we have these tools that have some evidence because of how our regulatory process works. There's a lot of evidence behind bariatric surgery and these drugs, right? So I understand there's this, that they're trying to have compassion to obesity, but I think it's just misguided, and to unnecessarily medicalize low carb diets seems like it just seems like a systemic bias that I don't know if they're even aware of. So maybe with that, Matt, you can give us some context and tell us about this paper.
Yeah, of course. So you guys might have to stop me because I could probably go on about this paper all day. So really, as Tro said, there's three big guidelines that we can discuss. Our conversation is mainly going to focus around this paper published last year for low carbohydrate and type 1 diabetes, type 2 diabetes, and kids at risk of type 2 diabetes, which in my opinion is any kid with any component of metabolic syndrome. But they also include obviously obesity into that as well. So that's a very sizable portion of the pediatric population, unfortunately, nowadays. And one of the things that I want to really emphasize to the listeners, we'll go through the prevalence. So how many kids are having diabetes and obesity nowadays, and what the extremely poor outcomes of the standard of care is for type 1 diabetes. So this paper was published last year. The other guideline was published more for the Wegovy, which is semaglutide, and the bariatric surgery earlier last year. And then a few years ago, there was actually another guideline that was published on using low carb diets for type 1 only. And that was basically a medical management guideline. And so we're basically going to focus on these three. There are four problems that I think we had with this paper, and it really compelled all of the authors and the co-authors on this paper to put in the time and effort to get this thing turned around pretty quickly and get it published a few weeks ago, even after just a very few months after this original guideline was published. And I want to say that all of the authors, put our names on some comments on the original guideline back in October. And the American Academy of Pediatrics, Pediatrics is the name of their journal article or their journal. And they said that if you submit a comment, we may publish it as an editorial. And that's all we were hoping for, was to open up a conversation. We submitted the comments and basically silence. Nobody had any other input. Nobody had another comment. We never were reached out to by anybody. And so we decided to take matters into our own hands and publish our responses in a more formal paper in the Journal of Metabolic Health. So I'll go over the four big problems I think that this current guideline has, and then I'll take a quick break and see if Laura wants to add anything. But essentially, first and foremost is this and other guidelines from pediatrics conflates a 4-to-1 or a 3-to-1 ketogenic diet with a well-formulated or whole food or a modified Atkins ketogenic diet. And we'll spend a little bit of time on that because I think that's really some of the crux of the issue. But even disregarding that, they basically over-medicalize one of the most nutritious eating pattern styles out there. And then they discuss number 3, eating disorders, specifically in the context of low carbs and using low carbohydrate diet in children. And then finally, I think that there is I think this speaks to the bias you were talking about, Tro. And I actually have some select quotes that we can go over. They're kind of new quotes from the other guideline regarding metabolic surgery and using Wegovy in children. And I want to compare the language from these exact quotes from that guideline to this guideline, because I want them to be intellectually consistent. I want there to be, if they have problems with low carb, then I want them to have those same problems if they are present with other dietary patterns or interventions. And if they don't have those issues with the other interventions, then I don't want that to be an issue with low carb. Just be consistent across the board. Right now, it's very obvious there's systemic bias against low carb.
Yeah, I mean, I 100% agree, and I can't wait to sort of unpack it. I think I think one of the things that we have to try to do is formulate a new consensus and point out things that are not wrong, that are wrong, right? And the whole exercise of getting, Dr. Eric Westman, Dr. Mark Cucuzzella, yourself, Dr. Laura Buchanan, Dave Dykman. Who am I missing? Is that the whole crew on this paper? The whole point of getting multiple people together on this was to, have a collaborative approach to responding. And I hope that this makes it onto their radar. And one of the things that I think is important to note, the first author from the guidelines for the American Academy of Pediatrics consensus statement on low carbohydrate nutrition has been paid in the past 5 years $250,000 by the makers of GLP-1 inhibitors, GLP-1 agonists. Those are new Ozempic drugs. And one of my issues was that wasn't listed as a potential conflict, right? And I find when you're talking about nutrition and the impacts of nutrition, and it should be listed as a conflict. So I was just disappointed on all accounts. And, I think it was important to get together with you both and the whole team and highlight the specific points that I think you're about to rebut, because a lot of them I felt were misguided.
Yeah, I totally agree with you there, Tro. And I wanted to, before Matt does dive into those points, go back to something Brian had said, and I just totally agree. The complications that we see clinically on a regular basis from bariatric surgery, from GLP-1s, is something that should not be underplayed, especially with bariatric surgery, because many of those complications you cannot undo, whereas with a GLP-1, you can just stop taking the medication if you're suffering from a complication. And so then to use this intervention in children is something that I think has to be taken much more seriously. And Matt actually also will probably go over some of these statistics, but over 70% of children following bariatric surgery, depending on the study you look at, have a nutritional deficiency. So this is in a time when, like Brian pointed out, everyone knows children are developing so rapidly, and now 70% in this population will have some kind of nutritional deficiency. And that's just what they're testing for. I don't know what else they're not testing for. So that's just, I think, something we really need to consider deeply when we make our recommendations as a medical community. And with that, I'd pass it back to Matt and see about him also telling us a little bit of the background where our statistics are as far as obesity in children, prediabetes, type 1, type 2, and knowing some of that background as we then talk about this paper.
Yeah. So to compare it to, I'm going to call the guideline that discussed metabolic surgery, bariatric surgery, and the GLP-1s in pediatric patients. I'll just call that the obesity guideline. And then this current one that we're actually rebutting, I'll just call it the low-carb guideline, because it's very helpful if your listeners just look at these papers, they can see the difference. They really set the stage for how prevalent obesity is in children in the obesity guidelines. They really set the stage that we have to do something about it. We have to take, a little bit more measures than we have in the past. And here are some of the bad outcomes that these kids are experiencing. Meanwhile, for the low carb guidelines, they really just went right into why low carb is not good for type 1, type 2 obesity without talking about any of the prevalence, any of the complications, et cetera. So currently for type 1 diabetes, the recommendations are you should get your 50% of your calories should come from carbohydrates, which is about 100 to 150 grams of carbs per meal. And then, so that's only for type 1 diabetes. We'll talk about their dietary pattern recommendations, which are, we'll just talk about those actually in the eating disorders, because actually, in my opinion, the points they bring up against low carb are also valid for the main dietary pattern recommendations they make for improving metabolic health in children, period. So then let's look at the prevalence and the outcomes. So in about over the past like 2 decades or so, type 1 diabetes has increased by about 50%. Type 2 diabetes has increased by about 100%. In type 1 diabetes, the outcomes with this current standard of care are awful. The average A1C is 8.2%, where the goal is 7%. If you get diagnosed with type 1 diabetes and you don't do, and if you're in the standard of care with that high A1C, you can expect about to live 15 years less than somebody that does not have type 1 diabetes. And after a decade of being diagnosed with type 1 diabetes, about 60% of people will have neuropathy, which is the pins and needles sensation. The nerves are dying essentially, and you're going to have loss of sensation in your hands and your feet. 27% will have retinopathy, which means that stages of blindness. And then 5% will have some form of kidney disease, nephropathy is what we call it, which is the beginning stages of needing to go on dialysis within a decade or a couple of decades. They've also done MRI studies on children in type 1 type 1 diabetes with these kind of elevated A1Cs, and they actually have decreased brain volume. And they find actually, because this is a big point about low carb, they say low carb negatively affects growth. Well, dysglycemia actually negatively affects growth. If we can actually get blood sugars under control, kids will grow happily and healthily. But if they're on the glucose roller coaster from a lot of the standard of care, then that negatively affects growth. One of the sayings I saw recently, I may butcher it, but it's basically aim small, dose small, and then or basically if you eat a small amount of carbohydrates, you only need a small amount of insulin. But if you eat a large amount of carbohydrates, there's a lot more room for error there. And that's kind of what Bernstein, who was the forerunner of all of this, was arguing for. If you don't have the carbohydrates, there's less room for error, and you can keep your blood sugars a lot lower. So that kind of leads us into this initial paper. That's the background. That wasn't discussed at all. They really just went straight into a low carb diet. And right off the bat, what they did is they looked at literature only at 4-to-1 or 3-to-1 ketogenic diets. So what are 4-to-1 or 3-to-1 ketogenic Back in the early 20th century, we used to use ketogenic diets to lower the seizure risk of children that had epilepsy. We basically only had a few seizure medications at that time. And if a child had seizures through those medications, there wasn't a lot of interventions. So we would offer ketogenic diets, and in general, about 1/3 of children would go seizure-free on a ketogenic diet. 1/3 of children would decrease their seizures, and then 1/3 of children would be largely unaffected. So about 2/3 of children would be helped by this diet. That's important because the thing that helps the seizure threshold, the thing that raises the seizure threshold and decreases the risk of seizures, are the ketone bodies that the brain uses as energy. So you want to have a very wide buffer in order to keep your ketones as high as possible, because if they drop below that threshold, your risk of seizures goes up. So in order to do that, kids would eat 4-to-1 ketogenic diet. 4-to-1 just means you're eating 4 grams of fat to every 1 gram of carb and protein. If you do the math for that, that's about a 90% fat diet. Meanwhile, when we look at the modern well-formulated ketogenic diet, modified Atkins diet, a whole food ketogenic diet, those are actually about 70 to 75% fat. And so really, I like to start with the outcome. What is our intervention trying to achieve? I do not put people on a 4-to-1 ketogenic diet to improve their metabolic health. I put them on a modified Atkins diet. I put them on a whole food, well-formulated ketogenic diet. And maybe eventually actually increasing fat and decreasing protein is a lever I eventually pull. But I don't know of a single practitioner, a single provider that is using at the very start a 4-to-1 ketogenic diet instead of these the modified Atkins diet. So they didn't address this issue at all. They never, it's basically it's the difference between a vegan diet and a lacto-ovo pescatarian diet. Like the AAP would never make that conflation for those diets, but yet they did it for this particular eating pattern, and that kind of gets propagated throughout the rest of these recommendations. What do you guys think of that?
I mean, I worked on this paper. I think this is the basics right here. Okay, they had literally one publication, right, on something that is what's widely used, the widely accepted keto, low carb, Atkins style diet. They had one trial, and otherwise they used a trial for, in a population that's on multiple medications for seizures. It like made zero sense. It absolutely made no sense. Almost disingenuous. It's like an insulting argument to make to people with a basic intellect. So this I thought was the strongest point. And if you look at your graph on the paper, they had like 16 trials versus one, right? So it pissed me off and got me angry. I'm sure Brian's blood is boiling like ours did.
Yeah, it's it's the same thing, and you see these studies they do. They'll say, okay, there's a ketogenic diet, and they're putting them on tons of seed oils and processed stuff that's horrible, and you go, okay, that's not very good. Like, at least make an attempt to make it a reasonable. Let us run a study and look at it against what you're talking about, and so that's the hard thing is people go, and you see, and this bears out, like when you go to the supermarket and you see stuff that says ketogenic, and you look on the back and it's all terrible oils in that. It's like, okay, if you want to die, that's probably a good thing to eat. So I think there's there's definitely a bias that way of not saying, let's do a well-formulated, have people that know what they're doing run the studies, not people who are, don't have that dietary bias. And I think at least making it a fair study. And we've seen more and more of that in medicine in general, where they do outlandish doses of medicines to say it doesn't work or it does work. And you look and you go, that's not physiological what we would typically give a person, So it's hard when the studies are bad that they're basing it on, and they're making these generalized recommendations on one study.
Yeah, and I think a lot of what they said could have been avoided if they had just one. Like, I would have volunteered. I don't even need to be an author on their paper. I would have volunteered and just said, hey, like, if they wanted my opinion, this isn't exactly right. You guys are looking at the wrong kind of diet here. You're kind of conflating this stuff. If you want to make this actually intellectually consistent, this is what you got to do. Unfortunately, I looked through, Tro did a little bit more research even than I did, because he found out about those other conflicts. But the people who wrote this are really smart. Like the author and the co-author and then the nutrition committee, like if you look at, I went through all of their descriptions, all of their biographies essentially on their academic portals, and their interests are short gut syndrome. Their interests are congenital cardiomyopathies and nutrition, and like premature infant nutrition. And these are things that are incredibly important, and you have to have really good guidelines for. Zero mention of low carb. Zero mention of therapeutic carbohydrate reduction. There were endocrinologists on there, but as we know, that doesn't really mean a whole lot to the low carb community. So, but the other thing that I think was actually, there was a single citation that was positive of before we get to the rest of the 2, 3, and 4 points real quick. The single citation that was actually positive of low carb was the type 1 grit paper. So for your listeners, this was the paper that was published in 2018. It was essentially a survey of either parents who had children that had type 1 diabetes or people that had type 1 diabetes themselves, 300 people. It was published by Bernstein was on it, Hallberg was on it, Westman, Yancey, Ludwig, Lenners. Really good. Basically, it was a survey. So obviously there are limitations to that. But I think the thing that's most frustrating to me is there was no curiosity that was created even after this paper. Essentially, like I said, the A1C average in type 1 diabetes is 8.2%. Everybody on this survey was low carb. Their average A1C was 5.7. So you went from 8.2 average to 5.7, and this was published in Pediatrics back in 2018. The interesting thing is they used this as partly saying, well, low carb has some interesting data behind it. But the paper ultimately made this into a bad thing because they found in this survey that 25% of the participants did not disclose low carb to the clinician, and 50% that they felt unsupported by their clinician. They did not disclose low carb to the clinician because of exactly what this guideline reported is we're going to label you as having an eating disorder. We're going to need to measure your carnitine levels every 3 months. We're going to need to get a DEXA scan. We'll go over everything that they would actually recommend in a bit, but we're going to need to get a DEXA scan after 2 years and then every year or some nonsense like that. So they actually took this paper that, in my opinion, should have made people, it should have been curious. They should have just said, wow, this is good stuff. We gotta investigate this more. And actually, if you look at the comments on this 2018 paper, there is so many people commenting. People were very critical of this type 1 grip paper, whereas nobody was critical. We are essentially the only people even discussing this paper at the moment for this current guideline.
Yeah, and it's so much bias. That's the problem is I have a lot of intro. I know you do too, and all of us. We have patients coming in all the time go, oh my gosh, I feel better, my joints are better, my cholesterol, everything's getting better, my A1C normalized. And when they tell the doctor what they're doing, after the doctor says, you're doing a great job, what are you doing? They tell them low carb or keto. So, and then they have to fight with them all the time. And so it's frustrating for the patient. So they're like, I won't tell them, I know what I'm doing now. I'll just do it on my own. And find another doctor just to check my labs and to reassure me that what I'm doing is correct. So it's a hard thing. I have so many, and the problem is the doctors don't understand it either. So they just go, it's bad. I just saw it on Oprah that it was bad or something like that. So I think without doing their own investigation. So I think that's why you're going to have this bias of people don't say anything. And, it's just so frustrating. So, but if that same patient does the same thing, and literally they go in and tell their doctor, I'm doing a modified Mediterranean diet, right? I'm just modifying by taking out the bread and pasta and processed foods. And then they go, great job. This is great. Then you're going to live forever now. They're eating the same thing. It's just all semantics.
Yeah, keto is a 4-letter word. I think it's important to talk about that because a ketogenic diet could involve a lot of exercise and include carbs. A ketogenic diet can be void of carbs and a lot of plants. A ketogenic diet can be very much animal-based. And as you said, Brian, it could be a modified Mediterranean diet without starches and beans.
And that's why, I think people have this thing in their mind that everyone on keto is eating butter and bacon all day long. So you don't realize, yeah, salmon's part of that, and maybe chicken, and maybe other healthier sardines, right? So it's and part of it's a lot of our own faults just for, some of the terminology we've used and not being precise in our language. I mean, there's ways to get into ketosis. Fasting, for instance, will throw you into a keto, even if you're eating more carbs. So doing, 24, 48-hour fast will do it, or time restricted eating. So I think it's really just, and I tell people, don't go tell people you're on keto, because it's such a cliche term, right? Everyone thinks, oh, I'm keto, so I can make brownies and cookies and all this stuff I've always binged on, and I just used almond flour and everything's fine. So I think there's so much of that where we have, there's a broad spectrum, and of course in the studies they're using this super high fat ketogenic diet that is the other thing is that's really hard to be compliant with, pouring olive oil on everything and butter like these kids have to do for a procedure disorder. It's totally different than what our general patients are doing.
Yeah, I'm curious, Matt. So, you're listed as a corresponding author. We wrote this paper sort of, really, I think, coming at them. Has anybody, were you surprised? It actually got widely shared. I didn't realize this, but I think it got like somewhere near, I'm looking at it right now, 5,000 article views. Roughly 5,000 article views, which is a lot for a paper like this. What sort of feedback did you get, or did you get any feedback?
No feedback. I'm disappointed in that. I really want there to be a discussion between the main stakeholders of the this pediatric guideline, which is the American Academy of Pediatrics. And, even just a, hey, this sounds interesting, like, thanks for posting it, would have been great. But I don't know if there's, I try not to assume the worst of people and their intentions without knowing. So maybe they just are formulating something. Maybe they're going to reach out any day now. But it's been out there for about a couple of weeks. And at the very least, it'll be helpful for the next time that they publish something like this. Like, there will be more low carbohydrate guidelines in pediatrics. And if they don't read this, they will continue to make the same mistakes. They actually, that original type 1 diabetes low carb guideline, medical management, was also published around 2018, and it made the exact same errors. There were zero citations for studies that used modified Atkins. All of the citations were for 4-to-1 ketogenic diets. One was for a pyruvate dehydrogenase deficiency, and then they were all just on children with epilepsy, with seizures. So it's history is kind of repeating itself. I am optimistic because we went through the process and we actually published our rebuttal, and I remain optimistic that they're also going to reach out.
Yeah,
Well, I'm old and cynical, so I say they just say, let's just ignore it till it goes away. We're just not going to address it. We're not going to draw attention to it, right? I think there's a lot of that happens in medicine these days. They go, just let it blow over. We won't have to address this stuff. But the problem is there's so many people having benefit that they're not going to let it just blow away. At least Tro's not. He'll get a loud blowhorn and go all over everything.
Maybe my Achilles heel. Look, I think the one of the other things, and maybe I'm gonna, well, before we go on, Matt, was there anything about this paper that you think, we mentioned the eating disorders, we mentioned, was there anything else you wanted to sort of bring up that you think sort of highlights the errors in the mainstream thinking?
Yeah, let's just briefly discuss the monitoring, because I think it serves to highlight just how out of touch that these recommendations are with what we see in clinical practice as just people who recommend therapeutic carbohydrate reduction for our patients. So they essentially recommended blood draws. So you're essentially sticking a child to get blood, and you're doing that at baseline, 1 month, 3 months, 6 months, 9 months, and 1 year. So you're sticking a child 6 times if you recommend a low carbohydrate ketogenic diet to treat their obesity, period. It doesn't matter. Like, this is a guideline for both type 1, type 2, and obesity. So 6 times in the first year, you're getting magnesium, zinc, selenium, vitamin D, calcium, phosphorus, a urine calcium, because you got to check for crystals, obviously, because that's a big risk on a keto diet. That's not correct either. Comprehensive metabolic panel, which is your electrolyte, liver, kidney function, a urine analysis, a beta hydroxybutyrate, a free and total carnitine level, which maybe you guys could talk about that as well. But essentially, you got to check for carnitine levels. A CBC because of platelet dysfunction was their reasoning for that one. A lipid panel, and then if you're on it for 2 years, you got to get a DEXA scan. So theoretically, the youngest child you would get a DEXA scan on, because type 1 diabetes can onset around year 5 years old. You'd be getting a DEXA scan on a 7-year-old child based on these guidelines.
Well, let me ask you a question, because I don't look at pediatric guidelines because I'm a internist. But first of all, are they recommending the same lab panels on kids who have a gastric bypass surgery?
Oh, great question. So the other thing that we can, I was going to bring up, I read through, I actually presented their original recommendations. January last year was the obesity guidelines where they talked about the metabolic surgery. And I'll give you the quote from that paper. So all they said was, in addition to recent data showing multiple micronutrient deficiencies following metabolic surgery, to highlight the need for routine and long-term monitoring. There were 0 recommendations. There were 0 tables. There were 0 lab draws discussed. That was basically the only sentence in about a 20-page paper regarding the need for monitoring any laboratory values after bariatric surgery, which we know. So they did say, well, you should find a certified metabolic bariatric surgery center in your area. But how much of that eventually do they get lost to follow up? They charge from the practice, and then it's our job as PCP to follow up these multiple nutrient deficiencies that may develop.
I
I'm
hear there's some other
staggered by that.
guidelines.
I'm
Here there's
staggered
some
by
other
that.
guidelines at the American Academy of Pediatrics that's controversial. You know, it's not the only one. There's a couple more that I think are
You would think, guys. I mean, I would think it. Like, if you want someone's carnitine level, where do you get carnitine from? Meat, right? So if they're eating more meat, why would you be concerned about having low carnitine? It makes zero sense. It makes zero sense to me.
I think the problem is it's likely that the authors don't have any experience with metabolic health.
Well, shouldn't you have experience before you make generalized recommendations on things? That's what I'm talking about.
Well,
It's like,
no, she has experience doing research for pharmaceutical companies, so she has clinical trial experience that I think is quite tangential to the topic at hand, but related. No, but related. Is my New York sarcasm just too much?
yeah. Well, I mean, it's just so obvious too, you know. And I would ask one more question before we get off the topic. What long-term data do we have on a 12-year-old kid or a 9-year-old getting gastric bypass surgery? What long-term data do we have from recidivism rate of becoming obese again in the next 8 to 10, 12 years?
They cited 6 studies in their obesity guidelines. Longest one was 5 years, average was 2 years. Generally, about 25 to 33% of children undergoing these surgeries will need another operation.
That's terrible.
And how much does that cost the system, right? I mean, it is astounding that they wouldn't. I mean, just as an example, I was just looking at a video. They were walking down through Russia, and they're looking at, down, and everyone's thin and healthy. So I Google, like, what do these guys eat? They eat 3 times a day. They make their own food. Very few people eat out, right? They're not eating a lot of processed stuff. They do eat potatoes, but they have a high fat diet also. And you go, these guys are all skinny and they're healthy looking, and they're like, there was not an obese person in sight. And you go, if we get into a war with these guys, they'll kick our butts because they could at least move, So you start realizing how much of it is just like, we don't really focus on getting out the processed food and the junk that we're eating. I mean, I think we can fall to one end of the spectrum, whether you're going to be more on the carnivore side or more of the vegan side. But I think if we can get out all the processed garbage in the middle, I just got back from Guatemala and I saw the disastrous outcomes just from, sodas and chips and crackers and what people are eating. Like, it's incredible. What do you think, Tro?
I think I think we're in a big problem here, right? I mean, you see that the devastation of processed food, right? You saw it firsthand in Guatemala, right? And we see it here in our pediatric population and our entire population. And then you turn to these organizations like the American Academy of Pediatrics, who are sponsored by Johnson's, Merck, Moderna, Sanofi, Abbott, GlaxoSmithKline, Sanofi, Regeneron, and you wonder why our guidelines are skewed. And it makes me mad. And it makes me very frustrated. And it's a sad world to be in. And the problem that I see is the 4 doctors here, we see it. We recognize it. We put the puzzle pieces together. We see the social problem. We see the regulatory capture. But then when we turn to our colleagues, right, the other 80%, they're very happy to see that the New England Journal of Medicine is, thinking about putting a carbon footprint on any medical intervention so that doctors consider the carbon footprint before they prescribe a medication or an intervention. It sounds like a great idea. It sounds like somebody really cares about the environment. But
except when you look at the carbon footprint of gastric bypass surgery, how much tubing and IV bags 100%. And all that stuff. I mean, come on. I mean, it's ridiculous.
But that's the problem is you think, I suspect that the 80% of our colleagues have these like great intentions. They want to serve society so well, but it seems like the picture is being lost. And like we're the only ones awake. And that's the part, when I look at this guideline from the American Academy of Pediatrics, I see a lead author with corporate industry ties. I see an organization, the AAP, with heavy corporate industry ties, and I see a paper that misses the point, right? And an unfair sort of system to evaluate lifestyle versus medicalized interventions, and an attempt to medicalize a lifestyle intervention. So I see a big systemic problem, and I think the people suffering are patients. And so it gets me excited when Matt's like, let's do this. It gets me excited, Brian, when you were like, let's do this podcast. Let's bring it out. It gets me excited when Laura's like, let's show people what we're doing. We got a study to publish. We got another study to publish. So I get excited. But
yeah, and I think all these things are so exciting. Like every time I go to Guatemala, it's the same thing. When I'm out in the country, I hardly see any diabetes at all, hardly any. And when I'm in the inner city, I saw 68 patients, 65 had sugars in the 300 or above, right? And the only difference is the people in the country are eating real food that they're growing, and they're eating twice a day or maybe 3 times a day, and they're making their own food at home because they can't afford to go out, and they don't have access to, all the fast food and everything that's on the corner. So as you get in the city, like we just dump out metformin and all these drugs on people, because what are you going to do? All you could do is educate. So I think it's one of those things where I think if these guys went to the third world and like just toured around a little bit, they would see that these guidelines really just don't make sense based on reality, not what one study showed.
Their recommendation. Oh, go, Laura. Yeah.
Sorry, no, I had to go back to something you said real quick to make sure I heard it correctly. So in the children that get bariatric surgery, 25 to 33% of them will have to have a second surgery within 2 years.
Yeah, these surgeries can be obviously it's worse for the laparoscopic gastric band, which they still cited as a positive citation for their basically supporting their argument. But we know in adult literature nobody does laparoscopic gastric bands anymore, and otherwise there's a lot of cholecystectomies and internal hernia surgeries that are done afterwards.
So just going back, we're telling our children you can't eat a well-formulated ketogenic diet or therapeutic carbohydrate reduction with as much meat as you want, plenty of non-starchy vegetables as much as you want, unless you do 9 separate blood draws per year. But you can have a surgery where 1 out of 4 chance you're going to get a second major surgery.
Makes complete sense, right? And you don't need to check the, you don't need.
This is within a couple of years.
We're not going to give you a schedule of vitamins to check that we know you're going to not be absorbing.
And we're not going to make nutritional recommendations. We'll just say, let's shrink it. You don't think these guys are going to stretch, the high school kids are going to stretch their stomach out eating garbage foods? Give me a break. It's ridiculous, because the reality is we really have to get to the root of the problem. Surgery is not going to fix the root of the problem. And it may help for a little while, but if 25% are going to have to get a repeat surgery, that is astounding, especially because you look at every time you go in and do a surgery, you have an increased risk of scar tissue, bowel obstructions, all these other things. You get appendicitis and then are afraid to go back in because you have scar tissue in your abdomen, all these kind of things that people don't think about. Yeah, you want to avoid surgery if you can.
Here's the genius level strategies for weight loss from that obesity guideline earlier this year. So you need to avoid skipping breakfast. That has a lot of data behind it that can decrease obesity. That's sarcasm. 2, there's this thing called the traffic light diet. We still got to talk about the eating disorders because I think that's one of the things that makes me the most frustrated. But the traffic light diet, where there's green foods, there's yellow foods, and there's red foods, and you got to eat unlimited green foods, and then you have to basically eat less of the yellow foods and try to abstain from the red foods. And then, of course, the famous 5-2-1-0, which is 5 servings of fruits and vegetables, less than 2 hours of screen time, 1 hour of physical activity, and 0 or nearly 0 sugar-sweetened beverages. And that's really made a dent in our pediatric metabolic crisis.
So, this is my problem, because I think that this problem that we're talking about, we're sort of beating around the bush. I don't think I think it's a huge systemic problem, and it finds itself manifesting in different ways. Nutrition guidelines, guidelines for drugs, guidelines for, new investigational products, right? These guidelines, they seem, just prone to huge blind sides. And the problem is I think most of our colleagues, I don't know that they care. I don't think that they care. They just want to feel that comforting blanket, like I did what the guideline says, and I'm done.
It's the
Right?
patient's
Well,
fault. It's the patient's fault. Yeah.
well, and also this whole at least perceived conflict of interest, these huge conflicts of interest we see in these studies and these guidelines. When you look at people who made the food, the food pyramid guidelines, you go, oh, who is funding them? And you go, oh my gosh, of course you're going to say to eat these things and exercise more, and when you're I mean, we're in a bad situation. I think the more we're around, the more you say, Tro, as an ops, example, and now they're all admitting this, but there was no data for social distancing. They shut down everything based on zero data. If you have data, then I'll look at it and we can look at it. We're looking for data. There's no data on these things. Now they're saying, yeah, we never really had data on that. But it was like, if you went against what all these recommendations were saying, you'd get thrown in jail or lose your medical license. It was like, it made no sense. There was no data behind that. And how many people now are suffering mental health issues and all these things? And I think the big thing that we're not talking about is the mental health of our kids, like suicide rate, depression rate, drug use rate, all the things, pornography, everything. I mean, we're a total disaster as a society. And a lot of this has to do with this dopamine, and inattention and just not being happy with life. So diet can affect this for sure. We see that.
Great segue. So they actually, for the eating disorders part of this, one of the eating disorders papers they cited was actually on mental health, and they tried to make the connection that low carbohydrate diets are unhealthful eating pattern, and that unhealthful eating patterns are associated with anxiety and depression. There's children nowadays have 10% of children, so 1 out of 10 have anxiety, and 1 out of 25% have depression. And that's not even adolescents at that point, because it gets higher as you get into the older age brackets. So the entirety of their argument regarding eating disorders, low carbohydrate diets cause eating disorders, is based upon these very, very weak, almost straw man type of things, going from point A and then going through point XYZ to get to point B. That was one of them. Literally didn't even mention low carb diets in that first citation. There was another citation they had which investigated, it just basically discussed low carb diets in type 1 diabetes. And this was published, I think, a few years ago. And I can just quote it. And it says low carbohydrate diets per se have not been clearly established as a predictor of an eating disorder. Don't even need to read anything more about that. You can move on to the next one. I don't even know why they cite that and say that low carbohydrate diets can predispose to an eating disorder. I think, I think Tro has some ideas on why they would do that to kind of conflate stuff like that. And then finally, they just said essentially diet culture itself is associated with dysregulated eating, which has nothing to do with clinician recommended intervention for improving metabolic health. And in fact, the American Academy, or the Academy of Nutrition and Dietetics, they have this pediatric weight management project. And they said, I'm just going to quote this here, there is zero evidence to suggest that weight management interventions result in worsening quality of life, anxiety or depression, eating disorder risk, or other psychosocial outcomes. So that's one. Two, in their own obesity guidelines, in the guidelines that discussed Wegovy and bariatric surgery, they said, the AAP themselves, pediatrics, concerns have been raised as to whether diagnosis and treatment of obesity may inadvertently place excess attention on eating habits and lead to disorder eating. The literature refutes this. So I think this is the thing that makes me most frustrated, is that you have multiple different organizations and the same organization saying literally less than a year prior in another guideline, you can discuss eating behaviors with children and it doesn't cause eating disorders. And yet we get to this paper and they don't even read their own guidelines. They don't even cite their own guidelines.
Well, what's amazing is, we always say association is not causation, right? So the fact that they're already obese, they have an eating disorder before any intervention starts. You already have an eating disorder. It's already there. It doesn't cause it. It's already there, right? So do we see people get worse or better? We see people getting better all the time. Because if we get your stress better, if you're not stressed all the time and stress eating, if you have good social support, all these things that are critical. That's why Tro and I have invested so much in building community and getting support groups and having people say, hey, I'm not the only one going through this. When you're on an island by yourself, it's scary. But when you go, hey, everyone else is doing the same thing I'm doing, right? It makes things a lot easier, and you're not the oddball. It's really I'll tell you some of the most surprising things. I see people who do more fasting, and they go, my binge eating got better with fasting, not worse. And I hear it all the time, and I'm surprised by it because I go, oh, I don't know. But more and more, Tro, I don't know if you're having that same experience when people, really cut the carbs. They go, it loses its power over me. Like I don't feel like I need to eat cookies. I don't crave cookies anymore. I feel like having a steak or something. You know what I mean? It's really odd to see these changes, and people still keep saying, yeah, if you deprive people, they're going to eat more candy and cookies and all that kind of stuff.
Yeah, I mean, there's no interventional data showing with intermittent fasting, with low carb eating, that there's an increased incidence of binge eating or anorexia or bulimia. So I think the concern is like just this theoretic concern.
It's an opinion.
Yes, correct. It's
without clinical experience to back that. That's the problem. It's just like social distancing 6 feet makes a difference. Like there was no data on that. You maybe your opinion, that's okay, but you can't put these wide. And this is what I'm saying is like medicine has become this. We make these broad, like can you imagine 25% of those kids within a couple of years are going to get repeat surgery again? How much does that cost the system that's already bankrupt?
Yeah, and think about that person going through that. Imagine being a 15-year-old and then an 18-year-old getting 2 surgeries. I mean, the human experience is huge. And I think the problem is I don't doubt that these people mean well. So I literally emailed the first author from the pediatric paper, and I brought her attention to our response. And I've yet to receive a response back. I'll keep you guys updated to let you know how that goes.
They're probably crafting it. It'll take usually takes a decade to respond to an email.
Yeah. So we'll see what the response is, but I'm excited. I'm excited that some docs are waking up. I'm excited by, Dr. Matt Calkins and Dr. Laura Buchanan. You guys are wind in our sails. I 100% agree. You can't, Brian's got too much gray hair and now he's going bald. I went bald a long time ago. We need people with, full sets of hair, to pick it up. And I don't think there's anybody better than you two.
Yeah, I think it's just getting clinical experience, right? You start looking at stuff and go, okay, let's try this out. If it's not working, we change tacks. So that's why we need young people who can do that, and you can't just put and that's what's I always thought was funny, Tro, is like, so our critics will say, oh, they're, what's the word they use?
Amazing.
Amazing. Yeah, I don't think they say amazing. No, they say you're dogmatic, or you're like, you say that's the only way. It's like, not at all. It's like, what works for the patient? That's ultimately what, how we're going to help people. So what works for you? If you have to have a cookie every once in a while to survive, okay, right? Maybe you'll change your opinion down the road once we get your sugars under control and everything. So yeah, I think there's so much that we're learning from a metabolic health, mitochondria, all this kind of stuff, how our energy works and how to partition energy. We're learning. We have so like the more I'm around, the more I say how much we don't know and how much we need to find out. So that's why having young kids who have a whole careers ahead of them to figure out this stuff. And then Tro, when we're old with our, sitting on the beach somewhere, we'll go, oh my gosh, that's how it works. Shoot.
Yeah, I mean, look, it's exciting times. It's nice.
Next week we'll be old sitting on the beach, Tro.
Yeah,
at least I will be.
Yeah, but it's a lot of fun. Dr. Matt Calkins, I cannot thank you enough for spearheading this. Dr. Laura Buchanan, your help with this was absolutely critical. And we'll link to the paper, and hopefully there's more papers coming out from both of you and more exciting things. Any last minute things to say? How can people find you? Where can people get you?
I gotta exit.
Where can people find you guys? Matt, Laura.
So I'm you can find me on Twitter on Matt Calkins, MattCalkins, MD. And just you can reach out to me there if you need to. I can leave the listeners with 2 things. One is just advocate for yourself. It's in this massive medical industrial complex we have. I do think everybody went into medicine. I truly believe to help people, but sometimes it's easy to get crushed under the wheel. So if you are your best advocate and just continue to advocate for yourself. And two, I'm just optimistic for the future. We were able to make this rebuttal with the help of the Society of Metabolic Health Practitioners and publish it in the Journal of Metabolic Health, which would not be something that I think could even be done probably even 10 months ago or a year ago. So we're on the up and up. Continue to advocate for yourself and advocate for what you know works for you.
Yeah, I James agrees, but we should, I think if you want to tag the authors or tag the AAP and try to share the paper and just bring more attention to it, I think that could be helpful as far as getting this information out there. And like Matt said, hopefully we can just increase the curiosity of other clinicians to see that this actually could be a really viable option to turn the ship of the chronic metabolic disease that we're seeing in our country.
100%. And how do people find you?
I'm Laura Buchanan, MD on Twitter. And if you go to drtro.com, I am also there accepting patients pretty much across the United States.
That'll change soon too, right? That'll change.
Yeah.
Soon. The handle will change soon too. Guys, thank you so much, both of you, and thanks, King James, for letting your parents join us. Bye, guys.
Thanks, Joe.
Thanks,
Bye.
Joe.